Hello, my name is Dr. Girish Kashyap, and welcome to the Health Podcast from Glory Dots, the platform where we bring the expert voices to simplify complex health topics and to empower you with knowledge. Today's episode is extremely important because we are talking about something we often take it for granted: our breath. From chronic asthma to lung cancer, and from pleural effusion to lung transplants, from AI to advances in medicines which are transforming how we diagnose and treat lung diseases. To help us understand this better, we are joined by Dr. Sunil. Dr. Sunil is known for his evidence based approach and has trained extensively across India, Germany, Canada, and United States. He has established a state of art interventional pulmonology program with an interventional pulmonology fellowship at Aster CMI Hospital, Bangalore, which is regarded as one of the finest in the country. Dr. Sunil also has a specialized clinic, Saptagiri Clinic, in the North Bangalore in judicial layout. His advanced training includes specialized work in pleural diseases, diagnostic and therapeutic bronchoscopy, with international exposure at globally respected centers like Cleveland Clinic in US, Tharolink in Germany. His experience at the lung transplant unit of the University Health Network was exceptional, marked by exposure to a high volume of pre transplant evaluation, patient optimization, and a lung transplant procedures. This immersive environment provided with him with substantial experience in ECMO utilization, structured rejections, surveillance, early and structured rehabilitation, and participation in multidisciplinary academic discussion with a mature high volume transplant program. With deep expertise in interventional pulmonology and critical care, Dr. Sunil brings with a global experience and compassionate clinical insight to the lung health. Doctor, it's truly a pleasure to have with you today.
Thank you.
So, Doctor, let's begin with something which people don't commonly understand. It's the interstitial lung disease or ILD. What exactly is the ILD?
See, basically, interstitial lung disease or ILD is an acronym what to be used. Is something which incorporates more than 200 different types of heterogeneous lung condition, predominantly affecting the interstitium, which causes distortion of the normal lung architecture. Predominantly, patients do present with hypoxia or oxygen gas transfer abnormality, and most commonly they encounter with symptoms like dry cough, breathing difficulty, and fatigability as a predominant symptoms. Generally, they tend to get misdiagnosed as asthma and COPD or infection if not properly addressed.
So, why is an early detection so critical in ILD?
Definitely, any ILD, it's just a progressive disease. Scarring or a fibrosis, which is most common factor in an interstitial lung disease, if not picked up early, definitely the patient tend to decompensate early. Any amount of exacerbation in the baseline lung function drops your lung functioning capacity exponentially, making more patient crippled because of his limiting activities. At the same time, early diagnosis by doing a CAT scan of a chest and a pulmonary function to assess your functional state of the patient carries a huge amount of picking up these patients in a much better way. And at the same time, we need to be mindful about the risk factors what the patient do carry with environmental factors, autoimmune disease by itself, tenet of connective tissue disorders, or occupational exposure. And recently, of late, in the last couple of decades, we had this COVID. Post-COVID fibrosis are the most common encountered entities, which could be contributing for the development of this particular ILD.
So, Doctor, what you mean is persistent breathlessness should never be ignored.
Definitely. That is a tenet. What is the take home message? Anybody coming with breathlessness, not only cardiac, equally the most common reason for breathlessness is any lung pathology. It can be asthma, COPD, ILD, which has to be addressed early before you could get into a catches of advanced disease, which don't have a much of a outcome in the therapeutic limitation of medications.
Okay, doctor, let's move on to the lung cancer. Many people assume lung cancer only affects smokers. Is that true?
No, no doubt smoking is a major cause for lung cancer, accounting more than 80 to 85%, and that is not the only one. The second-hand smoke or a passive smoking, air pollution, and genetic factors also adds on to this, which contributes to nearly 10 to 20% of non-smoking lung cancer. Of late, of late, we have been having this sort of a non-smokers, female Asian population, which contributes significant in the recent past, most commonly being adenocarcinoma in this particular patient, where the periphery of the lungs are much more involved in this condition.
So, doctor, what are the early warning signs?
So, anybody present with persistent cough, blood in the sputum, loss of weight, loss of appetite, and this particular shortness of breath, which is progressive, has to be closely monitored within India being an endemic country for tuberculosis. Be mindful about both. This needs a further investigation to pick them early.
So, one major advancement today is a lung biopsy through interventional pulmonology. Can you explain what that means, doctor?
Definitely, the lung cancer, which is one of the major leading cause of mortality across the globe. Now, 3 4 decades back, it's only based on surgical intervention was the of diagnostic modality which was very much utilized in this particular patients. But patients with the poor lung reserves, patients who have multiple comorbidity, definitely they wouldn't have tolerated a surgical intervention. To bail this sort of a pathological conditions, we come with a bronchoscopic modality where the minimally invasive procedures are done to at least pick the early features of cancer like a lung nodules, which can be accurately targeted by using a bronchoscopic modality, be it a radial EBUS or you have a robotic or navigation platform to accurately get the biopsy sorted so that we pick them early to establish the diagnosis in a concrete way.
So, does this mean patients can no longer need an open surgery?
Definitely.
Fantastic. Uh, what are the other procedures fall under interventional pulmonology, doctor?
So basically, when it comes to procedure, it can be divided into bronchoscopy, thoracoscopy, and a central airway interventions. When it comes to bronchoscopy, it can involve any pathology of the airway tubes, lung parenchyma per se, mediastinum, and pleural effusion. To address these lung nodules, which are the early features of any sort of a genesis of lung cancer, we have endobronchial ultrasound with radial EBUS, where we have a gadget which gets into the accurately into the lesion to get the biopsy sampled in a more accurate. If at all, if you go with the conventional bronchoscopic procedures of biopsy, the yield is 20 to 40%, which is quite disappointing for somebody with a lung lesion picked up, not into getting to the definitive diagnosis. In them, other navigational tools like electromagnetic navigation, robotic bronchoscopy, radiolibus comes up in terms of how accurately can stick a biopsy forceps in the lesion to get this sample sorted. At the same time, when it comes to pleural effusion, we have multimodalities like pleural aspiration followed by a pleuroscopic biopsies actually, and at the same time we do of anybody who has a resistant pleural effusion, sometimes we do place an indwelling pleural catheters and a pleurodesis is one of the therapeutic angle. The most scariest part are central airways. Any abnormality because of endobronchial mass, stenosis, or narrowing of the windpipe need a therapeutic intervention in the form of a tumor debulking, using a hot and cold method modality to debulk the tissue, airway stunting, and at the same time you use all this multimodality management to bail out the patients from a shortness of breath because of central airway obstructions.
So, doctor, what you're referring is the chronic lung disease like asthma, COPD are extremely common. But how do they differ?
This both are entity called asthma COPD. They generally tend to involve the airways or else air tubes. Invariably, they have a common pathology of where airway getting involved, but they have a different etiological process. Pathology is different, and treatment responsible is also differ in these two things. Where asthma is more common in the younger population group with a reversibility component adding on to this, as compared to COPD. most commonly encountered in the elderly. It's a progressive disease.
So, when should one get a pulmonary function test, doctor?
That's a fantastic question, actually. Now, when it comes to lung functioning capacity, everybody is concerned about what is the status of the lung when you have a trajectory. To sum it up, next 1 or 2 minutes, actually, somebody with 20 to 30 years of age will have a maximum lung functioning capacity in their lifetime. Each and every year you pass by, there's a drop in lung functioning capacity. So, somebody with present with chronic cough, shortness of breath, age more than 40 years of age, any occupational exposure. These are the most common indication which prompt us to go for a pulmonary function test. Normally, the rate of drop is 20 to 30 ml of FVC per year, as compared to somebody with COPD, where FEV1 is a better marker, which drops to the tune of 50 to 60 ml per year. And the extreme of interstitial lung disease, where the rate of drop can be more than 150 to 200 ml of FVC per year, making patients more symptomatic.
So, one condition that creates confusion, doctor, is the pleural effusion, fluids around the lung. How serious is that?
Normally, if you see, the normal quantity of ultrafiltrate of pleural fluid is 10 to 20 ml in the pleura. Because of pathological condition, there will be abnormal accumulation of fluid, making patient most symptomatic. General approach is anybody with pleural effusion. The first demarcation is whether to have a diagnosis of an exudate or a transudate. Any transudate is nothing but a systemic cause, either because of cardiac failure, nephrotic syndrome, or hepatic failure. As compared to the most challenging aspect is exudative pleural effusion, where the need for R is to do road the infection, is it part of a tuberculosis or a cancer. So this modality of either pleural tapping, which gives a yield to the 60 to 70%, as compared to pleuroscopic biopsy, what we do in our intervention procedure, takes a yield straight away up to 97% in terms of dissecting this problem of pleural effusion underlying etiology.
So, how do you differentiate between TB related effusion and the cancer, doctor?
Somebody with pleural effusion in India, still the major disease process is tuberculosis. Unless until there's a pretext of somebody with elderly, weight loss, cough with hemoptysis. Differentiating between these two things, pleural cytological report would be handy, or any exudative with low ADA, or ADA is nothing but adenosine deaminase, one of the marker of T cell maturation. Elevation is more classical with that of a tuberculosis. A range more than 60 qualifies slightly hinting towards the possibility of a TB. At the same time, we have a AFB smear. A rate is less than 10%. Culture rate is very disappointing to the tune of 20 to 30% in the pleural tuberculosis. So, any pleural effusion upfront has to be ruled out the possibility of TB, and based on the clinical context, surgical intervention is also needed to diagnose cancer.
So, now coming to something very advanced, doctor, lung transplant. Many people think it's either impossible or only done abroad. What's the reality?
Now we have moved on a reality where it was a sort of imaginary context. Now we are in the era where I'm glad to share that in India across there has been multiple centers where we have been doing lung transplantation successfully, and we are trying to match up with the data of the international what is when it comes to outcomes with post lung transplants.
Before we close on pneumonia, remains a common yet dangerous infection. How is it high risk?
Definitely, any pneumonia is nothing but solidification of the lung where the normal air sacs are filled with a fluid or an infectious exudates, which hamper the oxygenation, which is one of the serious condition, and it all depends on the presentation of subset of patients who are vulnerable because of the multiple comorbid condition, elderly age group, where they are more vulnerable to catch up this infection. Of late, we have been seeing COVID, a part of any sort of a respiratory infections, be it your influenza, H1N epidemics. These are most commonly encountered conditions which need sometimes admission if hypoxia persists. Definitely, the subset of patients which has to be careful is the extremes of age, any pollution, second-hand smoking or smoking per se itself is always a risk factor. At the same time, we are carrying a huge set of immunocompromised patients like diabetes, organ post-organ transplant with immunosuppressions, medications, HIV. These are subset of patients which has to be kept in mind in terms of treating a pneumonias.
So, doctor, now coming to something very advanced, lung transplant. Many people think it's either impossible or only done abroad. What's the reality? And if you can also brief the kind of the hospital care, which are quite advanced in India, which are quite specialized in these programs, and also about a bit of an insurance aspect of it. Who are all the people? Are they covered normally in this insurance coverage?
Yeah, that's a wonderful question. This is a sort of an eye opener for all the patient who has a end stage lung disease. Somebody with COPD, burnt out COPD, somebody with interstitial lung disease with a progressive oxygen requirement. These are the subset of end stage lung disease which needs a transplant as a boon for them to get this longevity and a quality of life, which will be a major factor in this sort of a subset of patient. I'm glad to share that in India, we have a good number of centers coming up in the picture to help this sort of end stage lung disease with a lung transplant as an option for them. Now, definitely, lung transplant, the awareness is a major hindrance. Apart from the technological expert and the skill set, what the center needs to be developed in India, there is no depth of it actually. Awareness and a timely referral is a major limitation factor what we encounter in our day-to-day practice. Now, most common indications like somebody would have an ILD or an interstitial lung disease with pulmonary fibrosis, severe COPD, pulmonary hypertension, cystic fibrosis, and a bronchiectasis. These are the conditions which is indication for your lung transplant. Somebody with a progressive worsening of their lung condition in spite of maximum medical therapy. Somebody who goes on oxygen, where a necessity becomes a lifestyle, where oxygen exponentially start increasing over a period of time. Any small existing activity, oxygen drops, which needs additional oxygen support. And at the same time, any heart pressures, right heart pressure, generally with oxygen being on the lower side, the right side heart pressure goes up. There's also one more indication which has to be kept in to list somebody for a transplant. Transplant listing is not equal to referral. Somebody, as I mentioned about COPD, ILD, bronchiectasis, or pulmonary hypertension, patient has to be screened. Need for understanding of a therapeutic window of option of lung transplant. Refer to the expert center who can do this optimizing with fine tuning about the patient's overall condition so that they can be fit for the lung transplant. Now, coming to some of the challenges what we encounter in India, always donor optimization. Donor option is always scant in because of the awareness which is not that very well ingrained with the Indian culture. Cost is also a major limitation. Definitely in any metros, the cost of the whole episodes of this sort of a lung transplant takes you to 25 to 30 lakhs as an usual one start financial things, which can be challenging. At the same time, a late referral. Transplant is not a last option. It is the option which has to be discussed with the patient when we have a irreversible lung pathology markers at the early. So that referred a timely to our transplants team, they can optimize the general condition and they can take off from there to get a good outcome. Now, somebody who's very well primed, transplanted will have a better outcome as compared to somebody where we have taken a transplant as a crash thing where patient is already septic, multiple organ failure, getting into a transplant itself is a huge risk. The outcome may not be that great. If you see the longevity, 1 year mortality free interval is going up to 85 to 90%, which we are also trying to match up in Indian data. At the same time, 5 year mortality or survival is around about 50 to 60% what has been documented. We are also catching up with that. Now, coming to some of the misconceptions, it's always referred late, may not be. Once we do a lung transplant, patient will always be having a debility and always have a lifelong crippling. No. Patient can do his day-to-day activities with or without oxygen can also be attempted and that is a reality. At the same time, there is a careful selection of the patient is a need of the hour and before selecting for patient, whether the patient is fragile, what are the comorbid conditions what the patient has. At the same time, what is the rehabilitation potential which determine the patient to be listed for transplants.
Doctor, if you can kindly do a bit of more deep dive about this availability of the donors for these lung transplants, and also some of the common myths what people would have with patients in terms of availability of doctors, the short notice to get this done, and also the kind of a waiting period a common patient would has to endure to get a lung transplant.
That's a fantastic question. That will get into the microscopic level of how the lung transplant has been organized actually. As we walk about a medical indication where a end stage lung disease where the life will not be so comfortable without a transplant. Now, in this patient has to be listed. Listed means a government of India come up with a NOTO, National Organ Transplant Organization, and at the same time we have a regional ROTO and have a state level called SOTO, which is Jiva Sarthakate. Anybody who is eligible patient for a transplant will be listed in this after thorough investigations to make our multidisciplinary discussion team with your cardiothoracic surgeon, cardiac anesthesia, infectious disease specialist, and a transplant pulmonologist, where we chart out whether the patient benefits from only a bilateral lung transplant or should we offer them a heart and lung transplant also. Now, invariably, once the patient has been listed, now generally, who are the donors for this sort of a patient? Anybody who had a road traffic accident or a brain dead patient documented in a centers which is certified by the agency, which can be easily intimated to a Jiva Sarthakate based on the priority of the patient blood group and the patient's height and the lung parameters, we will be in a position to get this cross matching done, and patients will be retrieved from the donor hospital to the recipient hospital, where this procedure can take up at least 6 to 8 hours for a bilateral lung transplant to go through. Post transplant, the major challenge is infection, infection, infection. When we have already the lungs which is exposed to outside world, definitely, the risk of small infection may be beat your bacterial, fungal, viral, or most common things. At the same time, any foreign organ which has to be safeguarded from the immunity of a person by himself, we go on a immunosuppression regimes, which will tend to decrease your immunity, which can be always a vulnerable for infection. Infection and rejection. These are two most tandem things which has to be addressed in a comprehensive way to get a good outcome for the post lung transplant.